We continue OEC 6th edition, Chapter 21, Spine, Brain, and Nervous System Injuries, by looking at spinal motion restriction. In this video, we want to describe how to assess a patient with a suspected brain or spinal cord injury and how to properly care for them. For spinal motion restriction, make sure that all transfers of the patient are done with careful attention to limiting spinal motion. That may include use of a long spine board, a vacuum mattress, or a stretcher, gurney, or scoop stretcher. When using spinal motion restriction, a cervical collar is required. The spine should be further protected against movement with padding and bracing to fill voids between the body and the device. When a patient with a spinal trauma is moved without spinal motion restrictions, damage to the spinal cord may occur because of vertebral bone fragments intruding into the spinal canal. The algorithm to institute spinal motion restriction involves three elements. First, determine the MOI. Second, determine the reliability of your assessment and consider your exam findings. A useful mnemonic device for this is to remember MRE, mechanism of injury, reliability of assessment, and exam findings. In detail, the algorithm looks like this. For MOI, we consider falls, especially a fall from greater than a height of 3 feet, an elderly adult fall from standing, or anyone falling more than 5 stairs. For reliability of assessment, consider the patient's mental status. Are they alert and oriented fully? Are they responding normally to commands? And can you rule out signs of intoxication with alcohol or drugs? For exam findings, we consider decap bottles, specifically deformities along the spine or midline tenderness over the spine. When we combine the potential MOI for spine injury along with exam findings such as a positive physical finding of deformity or neurological deficit on the exam, we may need to include spinal motion restriction in our patient treatment. These are 5 cases that require spinal motion restriction. In more detail, our positive physical findings include deformity or tenderness over the spine, loss of sensation or motor function distal to the spinal injury, in extreme cases, decorticate or decerebrate posturing to a painful stimulus, or any sort of a skull fracture, including those that leak CSF. Spinal motion restriction is not needed for low energy injuries where we don't have significant MOI, a headache or brief loss of consciousness in an otherwise alert and oriented patient, or some sort of penetrating trauma that does not have associated spinal or neurological deficit. Now, if you suspect a spinal injury and cannot obtain an adequate exam, it is more important to transport the patient quickly and use spinal motion restriction during transport. Once indoors and you're able to perform an adequate exam, it may be that your spinal motion restriction can be removed.